Hello, this is a lecture on cardiac investigation. I hope by the end of this lecture you may know the different types of cardiac investigations, to recognize the indications to order each, which is when to order, and lastly to integrate the findings of each in the different patients' scenario. What are the types of cardiac investigations? They may be divided into two main categories, which is invasive and non-invasive, and a third smaller category, which is semi-invasive. By invasive, you mean that to introduce something inside the patient's body. You may introduce a dye, like urography in coronary angiography or cardiac catheterization, or a catheter. You may introduce a probe through the esophagus. You may introduce a drug to fasten the heart rate or to induce vasodilation. All these are the invasive or the semi-invasive. And the other big category is the non-invasive, where you are just dealing with the patient body surface. And it includes many investigations, which starts with the chest X-ray, the ECG with all its modalities, the 12 lead, the stress ECG, the Holter 72-hour ECG recording, which is called Holter recording, the tell-table test, and the 24-hour blood pressure monitoring, and the echocardiography, transthoracic echocardiography. By the invasive, the godfather is the coronary angiography, and by semi-invasive you may include dobutamine echo, where you introduce dobutamine as a cardiac heart rate fastener, or to increase the heart rate so as to induce ischemia, or the transesophageal echo, where you introduce the transesophageal probe into the patient's esophagus to see the posterior structures of the heart. The CT angiography, where a dye, the urographene or ultravest, is introduced through a peripheral IV cannula inside the patient's body, and the CT is taken, views are taken. And the magnetic resonance imaging, or the MRI, where you introduce a gadolinium substance to have the images of the cavity and the blood flow and so on, which is a sort of substance with some electromagnetic properties to have the imaging process. What are the indications to order an investigation? Two main indications: either to differential diagnosis of a symptom of a patient, or to differentiate a sign elicited by the doctor. If your patient have a chest pain, after a good detailed history, you may need to have either 12 lead ECG, stress ECG, or you may order CT angio or coronary angiography, either having a invasive or non-invasive test. You may start with the non-invasive and to proceed to the more invasive test. If a patient had a non-specific symptom, just like dyspnea, and you heard a murmur, whether systolic, diastolic, continuous, whatever, you may order an echocardiography, whether transthoracic or transesophageal echo, to see the origin of this murmur, the severity of the lesion, or the site of the lesion, and the severity of the lesion, and the secondary consequences of this lesion in the form of cardiac dilatation or chamber dilatation or impairment of the left ventricular function. How do they operate? We will start with the non-invasive test, and the best is the chest X-ray. For the cardiac investigation or the cardiac views, you have to have a PA view for the assessment of the cardiac chambers and the pulmonary vasculature. It's a PA where the tube of the X-ray is just behind the patient and the film is in front of the patient. The image is taken while the patient in full inspiration. It gives you a very good idea on the lung vasculature and the cardiac size or the cardiac chamber size. In this view, you have the left view, it's normal vasculature and normal cardiac cycle. In the right chest X-ray, you will see that the cardiac size is much increased. It occupies more than 50% of the chest cavity, and the bronchopulmonary vasculature is much increased as indicated by the green arrow. You just compare between the right and the left X-rays to see the difference. The second non-invasive test is the ECG or the electrocardiograph, where it records the electrical signal of the heart from the body surface. It identifies the heart rate, the conduction disturbances, and myocardial ischemia. It's a simple test that can be applied during rest, which is called 12-lead ECG, as seen in the image. Stress ECG, where you just stress the heart by some sort of treadmill or bicycle, and monitoring or recording the ECG during daily work and activity and during sleep, which is called Holter monitoring. This is an image of the stress ECG. It's a simple test that can be applied. This is the stress ECG, where the patient is on the treadmill on the left image or on the bicycle in the right image, and the ECG is recorded at rest, during peak exercise, and at the recovery stage, where myocardial ischemia or exercise-induced arrhythmia can be recorded and identified. The Holter monitoring, it records ECG throughout your daily activity, maximum exercise, sleep, over 24 to 72 hours, and sometimes up to 1 week. It's helpful to have a short diary from your patient and to instruct him to push the event button when he got the symptoms he complained of. As you see in the bottom, this is a sample of Holter monitored diary of a patient, where he marked the time to sleep, where he took the medicine, when he took the medicine, when he ate his breakfast, and you can correlate these activities with the ECG recorded. This is how we apply the Holter monitoring. It is a simple recorder with 5 to 7 electrodes that will be attached on the patient chest, and on the bottom right, this is how you get the recording of the ECG. With the red arrow is pointing to a short episode of abnormal ECG QRS complexes occurring at a faster heart rate. This may be the complaint of the patient. The third is the tilt-table test, which exhausts the neurocardiac axis to test for the integrity of the neurocardiac reflexes that operate to avoid cardiovascular collapse. By the neurocardiac axis, we mean the reflexes that operate when you stand more than 15 minutes. So it initiates vasoconstriction to avoid peripheral pooling of the blood in the veins and avoid the postural hypotension. This is one aspect of the neurocardiac axis. 24-hour blood pressure monitoring, it measures the blood pressure at certain intervals throughout the day and night. It can detect white coat hypertension when you measure the blood pressure in your office or the clinic and the blood pressure is high, while the patient said, no, I have no hypertension at home, I measure it by myself or by my doctor, it's normal. This is what's called white coat hypertension. The patient got hypertension only when he visits his doctor. Also, it estimates the daily cardiovascular burden. Normally, when you sleep, the heart rate and the blood pressure should drop. If this doesn't occur, the burden is increased on the cardiovascular system throughout the 24 hours. And it carries risks on the heart as a muscle and the blood pressure or the blood vessels as capacitance vessels. It monitors the efficacy of antihypertensive therapy. If the patient is hypertensive and you are giving him 2 or 3 or 1 medication and you want to measure the efficacy of this antihypertensive therapy, 24-hour blood pressure monitoring is the tool. Echocardiography, it is an ultrasound imaging of the heart that allows the visualization of cardiac structure as a 2-dimensional slice. It's used to assess different cardiac structures and function. As you see on the bottom images, this is the apparatus. On the left, the patient is lying on his flat. The probe is in the hand of the doctor or the examiner, and the images are on the screen. On the right, this is how the heart, the 3 structure is converted into 2-dimensional structure. The transesophageal echo is a modality which is semi-invasive that helps to detect valvular dysfunction, especially prosthetic valve, as it produces a lot of noise which is interferes sometimes with assessment of its function. Left atrial thrombosis as a source of embolization. Left atrium is a posterior structure that is difficult to be visualized by the transthoracic echo. The presence of ASD, especially in adult patients, where the atrial septum is located some sort in a posterior aspect, and it's difficult to be assessed properly using the transthoracic echo. And in the cases of aortic dissection, where the probe of the echo can detect or diagnose the presence of dissection up to the mid-thoracic aorta. Stress echocardiography, this is a semi-invasive test. It is to obtain echocardiographic image of myocardial segments, and which is called segmental myocardial function and global function at rest and at different grades of pharmacological stress. You may apply dobutamine as I said to you, a cardio accelerator, increasing the heart rate, or dipridamole, which is a vascular dilator, which leads to shift of the blood from the diseased vessels, coronary vessels, to another healthy vessel, which gives you this contrast and will help you to see the ischemic areas more. Diminished segmental or global myocardial function indicates the presence of ischemia induced by the diseased coronary. And the most, or the godfather of the cardiac investigation, invasive cardiac investigation, is the cardiac catheterization, where left-sided angiography through the femoral or the radial artery to assess the coronary artery disease. It takes around 20 minutes with patient mildly sedated. It may be done on the right side using the femoral vein to obtain oxygen saturation from different cardiac chambers so as to detect intracardiac shunts such as ASD, VSD, PDA. This can be done, the cardiac catheterization can be done by radio-opaque contrast material, injection of radio-opaque contrast material as called the urographene into the catheter and into the coronary tree, and multiple cine views are obtained. As you see on the left side, this is the left coronary system, the left main, the LED, and the left circumflex artery. It's completely, the most left image is completely normal. the left middle or the middle left shows an stenosis in the left LED or left anterior descending artery. On the right image, there is the right coronary system. The most on the left side of this is the normal right coronary, while the arrow shows you stenosis in the proximal part of the right coronary artery. Opacification of this coronary is done by using the dye, which is urographene or ultravest, injected into the catheter, through the catheter into the coronaries. Cardiac CT, it is a semi-invasive test. It involves the use of ultra-rapid CT scanners gated by the ECG to obtain thin cuts of the heart and vessels. You can inject a smaller amount of radio-opaque contrast, maybe 50 cc's of radio-opaque contrast is injected via a peripheral vein for the imaging of the vessels. You have also to get some prognostic without the use of the dye. You can have some prognostic information in the form of the calcium scoring system, which usually classifies patients into high risk of having a coronary artery stenosis or atherosclerosis by having a high calcium score, or low risk by having a low calcium score as patients to have coronary atherosclerosis. This is the cardiac CT images on the bottom of the slide. You can see that it is used for delineation of the heart chambers or the heart vessels. It's very useful test to obtain a good idea on the anatomy, both on the vessels or the chambers. The vessels include the aorta, the pulmonary, and the coronaries, and also the grafted vessels. It is considered the golden standard investigation before coronary angiography in patients who underwent coronary artery bypass graft. The myocardial perfusion imaging, this is a semi-invasive test where you inject IV injection of gamma emitting substance, which is called technetium, with a short half-life during rest and at peak exercise. These gamma rays are detected by special camera and detectors and are transformed into an image that reflects the myocardial blood supply delivered by the coronaries, what's called myocardial perfusion. In the bottom right, this is an image during rest and exercise. The top row is during exercise or stress, and the bottom row is during the rest image. As you see, there is a defect in the anterior segment, which goes with the LED ischemia. We have also more advanced cardiac investigations, which are the Positron emission tomography, which is called PET. It investigates both myocardial perfusion and metabolism by injecting radioactive glucose. You are here testing both perfusion by injecting radioactive material, and you are testing for the cellular metabolism by injecting radioactive glucose. The mismatch between perfusion and the metabolism indicates ischemic viable myocardium. It is ischemic, but it is still living, so it will benefit from any form of revascularization, either by putting a stent or by undergoing a coronary artery bypass graft. The last is the cardiac magnetic resonance imaging. It images the resonance produced by the hydrogen content of the tissues when exposed to a strong magnetic field. This is the idea of the test. It's best in tissue characterization. So in the cardiac investigation, its place in the cardiac investigations is to differentiate between different types of masses you may find in the heart, and to properly delineate between viable myocardium, viable living myocardium, or scar tissue that is the myocardial cells has been transformed into pathological fibrous tissue. The take-home message is your stepwise order of the investigation is the most proper way to diagnose your patient, at least expenses and hazards, as every investigation has its intrinsic or inherited points of weakness. Most of the investigations are costly and they have its own inherited defects. So how to use them in a stepwise and wise way, this is the most proper way to reach your goal in diagnosing your patient. Thank you.